Okay, it's a great pleasure to introduce Dr. Maia Majumder. She's currently a faculty member at the Harvard Medical School and Boston's Children's Hospital on computational health informatics program. And she did her PhD at MIT, and her research interests are in artificial intelligence and machine learning for public health, especially surveillance using diverse digital and especially non-traditional data sources. She's been really active during COVID-19 with a lot of work on modeling and forecasting, including some of the earliest estimates of the reproduction number. And also she did a lot of earlier work on measles and other diseases, which I hope to chat with her later about. So Maya, it's a great pleasure to have you speak in our seminar series.
Thank you so much for the fantastic introduction. And, just to follow up, I am a faculty member in the computational health informatics program at Boston Children's Hospital and Harvard Medical School. And today, I'll be discussing a few of my research group studies at the intersection of machine learning and public health. I've been applying machine learning methods to public health problems for about half a decade now and have responded to several global infectious disease crises since 2014. I think many of the folks on the line are familiar with what some of those have been, but that includes, Zika in Central and South America, Ebola in West Africa, so on and so forth. But my ongoing research regarding the COVID-19 pandemic will be front and center in my talk today. That said, I am very happy to discuss previous work in measles and mumps and so on and so forth as well, because I think many of us are eager to talk about things that aren't necessarily about COVID-19. So very happy to discuss that during the Q&A as well. And I will try my best to leave about, at least 10 to 15 minutes at the end of my slides today so we can discuss not only what I cover in the slides, but anything else that might be of interest. So we'll kick things off with a bit of context regarding the ongoing pandemic. Then from there, we'll move on to 3 of my research group studies from the first year of the pandemic that employ machine learning methods to better understand COVID-19. Because we have limited time today, I'll keep my overview of each study pretty high level, covering the research questions first, then the methodology used to address them, followed by findings, policy recommendations, and related work. For those who want to learn more, though, all 3 studies have been published already and are open access, and I've included citations throughout my slide deck to make it as easy as possible to find them. I'll also very briefly cover some of my team's more recent work, but there should be plenty of time left over, hopefully once again, for a Q&A session at the end of the lecture. That said, feel free to shoot me questions on Twitter as well if you prefer. My handle is at the top left of every slide. So let's get started. So as many of us on the line are aware, there have been over 240 million cases of COVID-19 reported worldwide since late 2019, caused by the novel coronavirus SARS-CoV-2, which is shown on the right here. These cases comprise only a fraction of total infections, though, due to something that we call underdocumentation. Underdocumentation has many causes, including the fact that many SARS-CoV-2 infections are mild or asymptomatic in nature, as well as insufficient volume of lab testing in the early days of the pandemic, a problem that persists in under-resourced communities, both in the United States and around the world today. Another reason for underdocumentation in the early days of the pandemic was simply because cases were often misclassified. The earliest cases of COVID-19 presented as pneumonia, which can have many causes beyond SARS-CoV-2 and may thus have been diagnosed as something else at the time. As is an issue with any novel pathogen, there is a steep, very steep learning curve associated with discovering even the most basic attributes of its characteristics in humans and its behaviors in human populations. For instance, the transmission of SARS-CoV-2 started in Hubei, China in late November 2019, as is the best estimate today. It wasn't until late January 2020 that sustained human-to-human transmission was suspected, which is when my group began researching the novel coronavirus and its epidemiological characteristics. Our early work involved assessing the transmissibility potential, often described as the base reproduction number, or R0, associated with SARS-CoV-2 in Hubei, China. The base reproduction number is often defined, as many folks on the line know, as the average number of secondary infections caused by a single index case in a fully susceptible population. As a result, it is population-specific and varies across contexts. One can imagine, for example, populations where individuals have many daily contacts may exhibit higher values of R0 than populations where individuals have fewer daily contacts, something that all of us are likely very familiar with. In a population where R naught for a given pathogen is estimated to be greater than 1, we expect the pathogen has epidemic or pandemic potential. However, because R naught can't be directly observed, we need to model it. And there are a lot of different models that let us estimate R naught. But early in the pandemic, we had so little data available that we decided to take a simple phenomenological approach to its estimation. Phenomenological models are strictly descriptive in nature. In other words, they can't tell us anything about the underlying mechanism of disease transmission in the population, but their advantage is that they require very little data to parameterize. So my group's estimate for R naught was the first on record, but was quickly followed by several others shown on right through a meta-analytical study we conducted in February 2020. Though there was variability across estimates, as is obvious from that figure, the mean was pretty consistent across studies, indicating that the R naught associated with SARS-CoV-2 in Hubei, China, in the earliest days of the pandemic was likely in the ballpark of 2 to 3, an estimate that most people have now heard over and over again. As the epidemic in Hubei quickly turned into a global pandemic, though, my group started to wonder just how different R naught was across locations and how the various non-pharmaceutical interventions that were implemented around the world would impact transmission in the months ahead, especially as new waves of transmission began in response to calendar events like the last holiday season. Now, given the complexity of the new questions we were interested in, we decided to take a more complex machine learning approach in the form of agent-based modeling to address them. However, ABMs haven't been the only machine learning application my group has explored within the context of the pandemic so far. Prompted by how quickly the basic reproduction number studies shown on the right of this slide were produced back in early 2020, we also became increasingly curious about the speed at which the scientific community was working to fill existing knowledge gaps to better understand the novel coronavirus. So, to answer this question, we turned to natural language processing techniques like principal component analysis and latent Dirichlet allocation to sift through the thousands and thousands of new studies that have been produced in response to the pandemic. During this bibliometric analysis, though, my group became increasingly curious about how gaps in knowledge might also lend themselves to the proliferation of misinformation. It's all related in the end. Because of the political context of the pandemic in the United States, particularly during the Trump administration, Americans have been uniquely vulnerable to misinformation pertaining to the pandemic. Thus, with an eye towards developing better monitoring and mitigation strategies for public health misinformation, my group tapped into novel digital data streams like news media and search query data to investigate misinformation events here in the US. These three broad research areas, ABMs for epidemic dynamics, PCA and LDA for bibliometrics, and news media and search query data for event-specific surveillance of misinformation events, comprise a few of my group's core scientific interests. And today, I'll be covering 3 studies from the first year of the COVID-19 era that offer a taste of the work that we're doing within each of them before briefly discussing some of our more recent studies of the intersection of COVID-19 and machine learning as well. So without further ado, let's get started with ABMs for epidemic dynamics. The paper I'll be presenting in this research area is cited at the bottom of the slide for those who are interested in reading it. In this paper, there were 3 big picture research questions that we aimed to answer through our agent-based modeling approach across 3 different populations of interest: Hubei, China, where the pandemic began; Lombardy, Italy, one of the hardest hit locations worldwide in the earliest days of the pandemic; and New York City, one of the hardest hit locations in the US back in 2020. Recalling the context dependency of the transmissibility potential associated with a given pathogen, the first question we wanted to answer was, how does R naught vary across locations? Second, recalling issues with documentation of infections that I mentioned at the forefront of this presentation, how does documentation rate vary across locations? And finally, recalling the number of non-pharmaceutical intervention policies that have been deployed around the world since the beginning of the pandemic, interventions that we're still employing in some regions today due to lack of vaccine access and emergence of variants. What is the impact of varying policy recommendations during a new wave of infections across locations? Our choice of an agent-based modeling or ABM approach to answer these big picture questions is maybe best explained by digging into what an ABM actually is. ABMs in our use case can be best described as mechanistic infectious disease models that simulate individual people or agents who are assigned predefined characteristics based off of existing data on the population or populations of interest, including region-specific contact matrices, which many of us are familiar with, household structure, age, sex, and comorbidities, among other things. The description cards shown on this slide describe some of the attributes that are defined for a given agent or individual to address the aforementioned variability that we expect across populations for our 3 questions of interest. By defining each agent's characteristics based off of population-specific distributional data, we're able to simulate epidemics within essentially a synthetic version of each population, including how interventions may curb disease transmission in said populations. So clearly, ABMs require a lot more data and computing power to parameterize than simpler models, which is part of why we didn't use this kind of approach right at the beginning of the pandemic. However, unlike simpler models, they can lend important insights into more complex questions, like the ones we were interested in answering for this study. To simulate epidemics in each of our populations of interest, we fed the agents for any given population through a susceptible, exposed, infectious, and removed, or SEIR style model, as is shown here. We used contact matrix and household structure data specific to each population of interest to inform transitions from the susceptible state to the exposed state, and we further partitioned our infectious state into 4 categories: pre-symptomatic, mild, severe, and critical, each of which were also assigned a probability of transitioning to one of the 2 removed state categories, recovered or deceased. Folks on the line are probably very familiar with SEIR models of the traditional compartmental variety, which are typically defined by ordinary differential equations or ODEs and treat each member of a given compartment as identical to one another. In these simpler models, all members of the susceptible compartment have the same probability of transitioning into the exposed compartment. All exposed members have the same probability of transitioning to the infectious compartment, so on and so forth. These kinds of simple models are popular because they are much less computationally intensive and complex than ABMs. However, they aren't optimized for taking into consideration intervention policies and their impact on transmission, an issue that is particularly important for 3 populations of interest, given shelter-in-place orders that took place at each location early on in the pandemic. Moreover, they can't capture the individual level variability that makes agents different from each other, something that's important to bear in mind given the fact that intervention uptake takes place at the individual level. In other words, just because an intervention policy is enacted in a given population doesn't mean that every group within that population will comply with it, something that we are seeing right now across the United States with vaccination and masking. This was notably critical to our research interests because we wanted to specifically investigate the impact of age group specific sheltering in place and physical distancing on transmission dynamics during future waves of spread in Hubei, Lombardy, and New York City. So to parameterize the SEIR model shown on the previous slide, we used a combination of empirical estimates and free parameters, as shown in this table. Notably, the probability of infecting an out-of-household contact is a free parameter that plays a really important role in estimating R0 across locations. Distributions for free parameters like this one were estimated using a Bayesian inference framework by fitting death trajectories for each population of interest against ground truth death trajectory data. Death trajectories were used as opposed to case counts over time because deaths have generally been a more reliable indicator of outbreak progress across locations throughout the pandemic. Though deaths obviously lag behind infections, they are more likely to be documented than non-fatal cases of COVID-19. That said, we did use ground truth data on case counts to estimate the documentation rate across locations by dividing reported case counts by the number of infections as ascertained from our ABM for each location. Our ABM fits against the ground truth daily death trajectory data for each population shown in small black dots, and the 3 panels in this figure were quite good across locations. The green line shows the median trajectory for ABMs, and the light blue how different individual samples from the thousands of simulated epidemics that we ran for each location. The red dotted line indicates when ABMs for each location initiated a reduction in contact across the population in response to non-pharmaceutical intervention policies, such as shelter-in-place orders. These policies were implemented at different times across locations, as is clear from the x-axis for the 3 panels. The factor by which contact was reduced following shelter-in-place orders varied by location. While information on this parameter was determined empirically from a survey study for Hubei, it was treated as a free parameter for Lombardy and New York. We did, however, compare our estimates for contact reduction in New York against mobility data from Unicast and found that our estimates were pretty similar. To further validate our fits against death trajectory ground truth data, we conducted several sensitivity analyses under varying assumptions of under documentation for deaths, as well as out of sample validation, as is detailed in the supplementary materials for this paper. Once we felt assured of our fits against the ground truth death trajectory data, we were able to estimate R0 for each location, as well as the documentation rate. Substantial differences in R naught are visible across locations in the early days of the pandemic, as shown in the top left panel, with medians of 2.23 for Hubei, 2.95 in Lombardy, and 3.2 in New York City, thus demonstrating important population level variability. R naught values, as estimated through a sensitivity analysis in which deaths were assumed to be underreported in Lombardy and New York City, which, unlike Hubei, were still developing outbreaks at the time of our analysis, is shown in the bottom left panel, and notably, the relative order of magnitudes across locations remains unchanged. Substantial differences in documentation rate are also visible, as shown in the top right panel, with consistently low documentation rates across locations, rates that are further reduced when conducting a sensitivity analysis in which deaths in Lombardy and New York City are once again assumed to be underreported, as is shown in the bottom right panel. Despite low documentation rates across locations, however, all three populations remained vulnerable to a new wave of infections as of this time last year, which is when this paper was in preparation for publication. More specifically, our models suggest that only 1.3% of Hubei, 13.8% of Lombardy, and 22% of New York City were infected by the end of our modeling periods for each location, the latter of which has since been confirmed empirically via serological survey studies. Given the susceptibility of all three locations to further transmission of SARS-CoV-2 last summer, we investigated the possible impact of various shelter-in-place strategies to curb transmission in the event of a new wave prior to the widespread availability of vaccines, with a focus on age group-specific interventions. Here, each column shows a different level of physical distancing by the population of interest, where contacts between all age groups are reduced to the given percentage of their starting value. The x-axis within each plot shows the result when the given fraction of a single age group shelters in place, in addition to physical distancing by the rest of the population. The result of this combination of sheltering and distancing is represented by a bar, where the color of the bar indicates the age group which engaged in sheltering, as shown in the key. The height of the bar yields the total fraction of the population infected or the number of deaths in the population in that scenario. Each row gives the results for a single location, where the first two plots show the fraction of the population which is newly infected in the new wave, and the next two plots show the number of new deaths which occur. We found that sheltering in place by a single age group had the potential to produce a protective effect against transmission for the entire population. But which age group had the greatest impact varied across our three locations, thus highlighting the importance of capturing heterogeneity, both within and across populations. Furthermore, the impact of sheltering in place was itself impacted by the level of physical distancing undertaken by the rest of the non-sheltered population. Here, 50% contact and 75% contact rates, which represent 50 and 25% reductions in number of contacts, are shown, with very starkly different outcomes with respect to infections, shown left, and deaths, shown right, in our three populations of interest. All in all, this work suggests that partial population sheltering rather than universal lockdowns, combined with physical distancing by the remainder of the population, may be a creative solution for reducing COVID-19 transmission in settings where vaccination has not yet reached the population at large, or in the future when variants of concern may be capable of vaccine escape, but that recommendations regarding who should shelter must be population specific. Given the impact of physical distancing as a supplement to partial population sheltering, we also provided a list of policy recommendations to improve the feasibility of physical distancing in our paper, recommendations that are still relevant today in under-vaccinated regions and areas facing new outbreaks of more transmissible variants. These include, but are not limited to, the implementation of shift work, staggering of work shifts, and cohorting of workers in workplaces, one-way aisles and age group-based shopping hours for essential businesses such as grocery stores, pharmacies, and so on, staggered admission for non-essential businesses such as gyms and restaurants, and remote worship services for religious congregations, many of which have been implemented in different businesses since the time of publication. Further recommendations, including the feasibility of sheltering in place within the work from home paradigm, are elaborated upon in the supplementary materials as well for those who might be interested. This all said, though our agent-based modeling structure has been peer-reviewed and published, we're still working on improving it through related and ongoing work that builds off of the structure I presented today and applies it to other locations of interest. Internationally, we've thus far expanded our model to India, and domestically, we've started work on developing state-level models that incorporate occupation into the agent characteristics as defined for each population of interest. For here and abroad, we're also working on modeling more equitable vaccination deployment strategies that exploit transmission heterogeneity and the fact that not all individuals are as likely to contract or spread SARS-CoV-2 as others, to inform risk-based immunization, particularly in regions with a limited supply of doses, as well as within the context of future booster shots, which we're already starting to deploy here in the US, that may eventually be needed in the face of emerging variants. Without question, this is a very active area of research where we expect to continue improving upon our published work to better inform the way that we make policy decisions moving forward. And we're excited to see where our ongoing work takes us. Now, let's dive into another research area of interest at the intersection of machine learning and COVID-19 pandemic: natural language processing for bibliometric analysis. As I mentioned at the beginning of the presentation, my group became particularly interested in understanding the evolution of research pertaining to COVID-19 due to how rapidly studies, including our own, have been produced in response to the myriad knowledge gaps that exist due to the novelty of the pandemic. More specifically, we were interested in answering three specific questions. First, given that COVID-19 has caused a multi-million casualty pandemic and related coronavirus diseases like Middle East Respiratory Syndrome, or MERS, and severe acute respiratory syndrome, SARS, thus far haven't, does the research that's been produced for COVID-19, especially given the speed at which it's been produced, differ in some way from research that's been produced for MERS and SARS? Second, what fields or topics were overrepresented and underrepresented in the COVID-19 literature that was published in the first few months of the pandemic, either as peer-reviewed papers or as preprints prior to the peer review study? And finally, how is the focus of COVID-19 research, namely the topics and fields investigated, changing over the course of the pandemic? There are a lot of cool results I want to share today that start to address these questions, so I'll only offer a very cursory look at the methodology we used in this particular study before jumping into our findings. The paper is cited at the bottom of the slide, though, for those who would like to dig into the more technical aspects. To start addressing our questions of interest, we turn to the COVID-19 Open Research Dataset, or CORD-19, a growing resource of scientific papers on COVID-19 and related historical coronavirus research. As of May 28th, 2020, which is at this point over a year ago, CORD-19 was already comprised of over 130,000 research papers. To save computing time, we decided to restrict our analysis to abstracts. And of the research papers in the dataset, about 100,000 had abstracts available for analysis. Among these, about 35,000 mentioned coronaviruses explicitly in the abstract, indicating that the paper itself was about coronaviruses rather than simply referencing coronaviruses in passing or in the citations list. Over half of these coronavirus abstracts were about COVID-19. The remaining fraction referenced other coronavirus diseases like MERS and SARS instead. After the filtering process shown on the previous slide, we used the resulting 18,412 COVID-19 abstracts and the 16,869 abstracts mentioning SARS and MERS as a source text or a corpus of documents for our analysis. Natural language processing was implemented on these 35,000 abstracts in two different ways. First, we conducted dimensionality reduction using principal component analysis, abbreviated as PCA. PCA identifies patterns of variance or principal components, abbreviated as PCs, that differentiate documents from one another, highlighting key trends in the data. For example, in a simple corpus with two mutually exclusive topics, such as machine learning and public health, the terms machine and learning would be correlated with one another. PCA would recognize these terms as an important source of variation, providing a way to differentiate documents about either topic, machine learning versus public health, by the frequency of these terms. Following PCA, we conducted topic modeling using latent Dirichlet allocation, abbreviated as LDA. LDA is an unsupervised probabilistic algorithm that extracts hidden topics from large volumes of text. Once trained to discover words that separate documents into a given number of topics, LDA can estimate the mixture of topics associated with each document, or in our case, scientific abstract. These mixtures suggest the dominant topic for a document that is then used to assign a document to an overarching topic category. For example, LDA may separate documents into two topics, one on machine learning and another on public health. And if a particular document's mixture is 60% machine learning and 40% public health, it would assign that document to a machine learning topic category. Findings from our dimensionality reduction via PCA suggest that the second principal component does a nicer job of differentiating literature about COVID-19 from literature about MERS and SARS, shown on right. It's worth noting that earlier PCs usually capture more variance than later PCs, but in this case, we see that PC2 captures more variance because certain aspects of pre-computation processing weren't conducted for the purposes of computational feasibility, as is detailed at length in the supplemental information that accompanies this study. To better understand what kinds of terms were driving the divergence we saw in PC2 between COVID-19 abstracts and abstracts pertaining to MERS and SARS, we examined the component values of the top 50 words on PC2. Here we see that on the left, lemmatized terms include words like patient, case, and hospit, which represents words such as hospital and hospitalization, among others. Meanwhile, on the right, lemmatized terms include words like virus, cell, and protein. Notably, in PCA, words with component values of the greatest magnitude on each PC most strongly drive the pattern that each individual PC recognizes. Here, this means that PC2 detects a pattern such that when protein appears in the text, patient appears less often. To learn more from the lemmatized key terms in the previous slide, we sorted them by their PC2 component values and then examined the percentage of COVID-19 abstracts and the percentage of MERS and SARS abstracts that mentioned each word. Here, COVID-19 abstracts are shown in orange and non-COVID-19 or MERS and SARS abstracts are shown in blue. It's immediately obvious that COVID-19 abstracts are overrepresented on the left-hand side, the side that includes words like patient and case, and underrepresented on the right-hand side, the side that includes words like protein and cell. Given that terms like protein and cell are more likely to appear in lab-based research and terms like patient and case are more likely to appear in clinical, modeling, or field-based research, this suggests that laboratory-based research regarding COVID-19 may have been underrepresented in the first several months of the pandemic when compared against MERS and SARS. Digging deeper, topic modeling via LDA also suggests stark differences in the topics covered by COVID-19 or SARS-CoV-2 related abstracts when compared against abstracts pertaining to other coronaviruses. 30 topics emerged as shown above, and 5 of these: 1, topic 14, outbreaks impact on healthcare services. 2, topic 15, testing for coronaviruses. 3, topic 17, epidemic cases and modeling. Topic 21, clinical care and therapeutics. And topic 25, lessons learned for epidemic preparedness, accounted for 58% of all COVID-19 abstracts and just 17% of MERS and SARS abstracts. In other words, COVID-19 abstracts were disproportionately concentrated in these 5 topics related to non-COVID-19 abstracts. We were also able to group the 30 topics that emerged into a few topic families, namely 1, clinical issues, testing and diagnostics. 2, societies and outbreaks, responses to mitigate them and their impact on society. 3, basic microbiological study. 4, general outbreak reporting. And 5, modeling disease transmission. Temporal analysis of these topic families over time indicates that publications between January 2020 and through the end of May 2020 were dominated by studies involving outbreak response in patients and healthcare services, with no sign of slowdown. Publications regarding viral mechanisms and biomolecular processes related to SARS-CoV-2 grew at a slower pace during this time period. And these results remain consistent when we reran our bibliometric analysis pipeline with data through July 2020 as well. This suggests that as of last summer, COVID-19 research was dominated by clinical modeling and field-based investigation, whereas lab-based studies lagged behind. With the help of colleagues and collaborators who conduct lab-based studies, we were able to determine that the most likely cause for the lag in lab-based research for COVID-19 had been due to massive federal funding cuts that basic science labs have experienced over the last several years. In other words, these lags were not at all due to the fault of basic scientists. Instead, they represent insufficient resources to do work that is essential to pandemic response, including development of improved diagnostics and condition-specific therapeutics. As a result, one of our primary policy recommendations coming out of this study is the need for federal funding mechanisms to prioritize lab-based research, both in the short term for emergent crises like the ongoing pandemic and through long-term mechanisms to enable a position of preparedness for future emergent crises. Since publication of this study, numerous lab scientists have reached out to my group and thanked us for providing quantitative evidence for their anecdotal experiences, which they hope will help motivate reevaluation and redistribution of federal funding to lab-based research activities. Indeed, we foresee that our bibliometric analysis pipeline can be utilized by federal funding agencies over time to identify possible special interest areas too. including persistently understudied topics, not only in basic science, but within clinical modeling and field-based science as well. As a result, we are keeping our pipeline up to date and will continue running it on the COVID-19 data set in the future to see what else we can learn about the information we're creating in response to the pandemic. We also plan to expand our bibliometric analysis pipeline to include clinical trial abstracts to unearth potentially understudied outcomes associated with COVID-19, such as the long-term effects of COVID-19, which to date remain poorly understood and have often been overshadowed by effects associated with therapeutics that are currently undergoing trials. Beyond bibliometric analyses, we would also like to further examine COVID-19 and other scientific literature databases using network science techniques to investigate the COVIDization of public health research. COVIDization of research may be defined as a phenomenon in which researchers who have not previously studied pandemics, epidemics, or coronaviruses are pivoting towards COVID-19 research for a whole host of reasons, varying from the availability of emergency funding to things that are a little bit less sincere, like opportunism. However, given the importance of domain expertise and experience when conducting research about COVID-19, the COVIDization of public health research has the potential to result in information generation that maliciously or otherwise doubles as misinformation propagation, as is showcased by several high-profile retractions that have taken place since the beginning of the pandemic. Of course, poorly executed scientific studies aren't the only source of misinformation that plagues the pandemic, which leads us to the third and final study that I'll be covering in depth today. In the broad research area of utilizing novel digital data sources for event-specific surveillance, this paper focuses on the public health impacts associated with the misinformation event that I'm sure many of us are all too familiar with: President Trump's April 2020 remarks regarding the off-label use of disinfectants as a COVID-19 therapeutic. For those who might need a refresher, however, let me read President Trump's remarks for you now verbatim. I see the disinfectant where it knocks it out in a minute, 1 minute. And is there a way we can do something like that by injection, inside, or almost a cleaning? Because you see, if it gets to the lungs, and it does a tremendous number on the lungs. So it would be interesting to check that, so that you're going to have to use medical doctors with, but it sounds interesting to me. Following the statement on April 23rd, 2020, my research group was interested in answering 3 specific questions. First, how did President Trump's remarks impact the behavior of the general public with respect to interest in purchasing, injecting, and drinking disinfectants? Second, how long did the impact of his remarks last? And finally, was this misinformation event associated with population-level increases in adverse health effects, such as poisonings? Like the bibliometric study, there were a wealth of fascinating findings that we discovered through this investigation, so I'll keep my discussion of the methods brief and focus primarily on the results. However, please feel free to read the paper cited at the bottom of the slide and the technical appendix if you'd like to learn more. To start addressing these questions, we first turned to internet search query data from Google to get a handle on what kinds of disinfectants the general public was searching for, both before and after April 23rd, 2020. Google search query data are fractional and relative. When interest in a search term reaches a peak for a given time period, this means that the term was most popular at that point in time. And whichever term in a series of terms was most popular among them peaks at 100. Here we can see that Lysol was the most popular term when searching for 9 disinfectants, and that it peaked around April 23rd, 2020. Other popular disinfectants included bleach and Clorox, with the remainder peeling away from the pack. With our initial search query analysis under our belts, we curated a set of search terms to represent 4 topics of interest: purchasing, drinking, and injecting disinfectants, as well as poison control, a proxy indicator for possible poisonings following the off-label consumption of disinfectants. As is clear from the search terms considered, we chose to focus on the 3 most popular disinfectants that appear to peak around April 23rd, 2020: Lysol, bleach, and Clorox. We pulled data from Google search trends for these search terms, but we also pulled news media data pertaining to these topics as well, so that we could implement a debiasing procedure to separate interest in President Trump's remarks due to media-generated interest from true interest in the off-label use of disinfectants. The autoregressive machine learning procedure designed to debias the search query data of media-generated interest is detailed at length in the supplementary materials that accompany this paper for those who might be interested. Prior to debiasing the search query data media-generated interest, we plotted our raw search query data, and the results, which are shown here, were stunning. The action-oriented searches that reflected off-label use of disinfectants namely drinking and injecting disinfectants, peaked immediately following Trump's April 23rd remarks. Then, rather damningly, interest in poison control peaked the very next day, results that are consistent now with poisoning reports that have subsequently been noted by the American Association of Poison Control Centers. Moreover, interest in these topics remained increased for an entire week following the misinformation event, suggesting that while most of the associated impact on population-level behaviors occurred soon after the event itself, the impact didn't dissipate immediately. Through debiasing to minimize the news media generated interest, we were able to marginally blunt the results that we saw across the topics of interest, as is shown in these 4 charts. But nevertheless, the overarching trends described in the previous slide remain consistent. We can't infer causation from this work alone, but the fact that internet search interest in poison control centers peaked after queries regarding off-label use of disinfectants suggests that search query data could be used as an early warning surveillance system for poison control centers in the future, a need that may be increasingly dire as false cures and prophylactics for COVID-19 continue to be propagated by those in positions of power. Which brings us to the policy recommendations that my research group made following the study. First and foremost, science communication at multiple scales will be necessary to combat sources of misinformation, including elected officials, even in the aftermath of the Trump administration. Second, a surveillance system for public health misinformation should be established using a novel digital data sources that allow us to monitor population-level behaviors following misinformation events. By designing such a system specifically for healthcare and safety service providers, decision-making tools like the early warning system for poison control centers I just mentioned can be effectively brought to fruition. With an eye towards establishing a surveillance system for public health misinformation, my research group is currently pursuing a geographic analysis to accompany the temporal analysis presented today to uncover spatial heterogeneities in population-level behaviors, and thus vulnerability following misinformation events, as well as sociodemographic risk factors that accompany such vulnerability to enable hotspot prediction of adverse health effects in response to misinformation events. We're also working on incorporating additional data streams such as Twitter to glean deeper insights into behavioral impacts following other misinformation events, including those that pertain to vaccines. Beyond the 3 studies we've just discussed in some depth, my research team has also conducted a few more recent investigations at the intersection of machine learning and COVID-19 that offer additional complementary perspectives into the pandemic. I'll go over some of the high-level findings from these briefly now to further enrich our Q&A at the end of the session. So in addition to modeling epidemic dynamics, bibliometric analysis, and misinformation surveillance, my team has been working with the telemental health service provider, Talkspace, to evaluate mental health responses to the pandemic since pretty early on in the pandemic. We started this collaboration very, very early, and because Talkspace provides SMS-based therapy to hundreds of thousands of patients, this project has given us the opportunity not only to analyze relevant data from standardized survey instruments like the GAD-7, which is shown on this slide, but to conduct content analysis via natural language processing on text messages too. The first study associated with this collaboration was recently peer-reviewed and published and offers insights into pandemic-related shifts in anxiety and depression symptoms during the first 6 months of 2020. We found that while there weren't significant shifts away from the pre-pandemic period with respect to incidence of depression-related symptoms, there were considerable shifts in anxiety-related symptoms, as is shown here. Furthermore, content and co-mention analysis of pandemic-related SMS conversations between patients and their providers during the first 6 months of 2020 allowed us to identify 24 additional symptoms outside of those included in the diagnostic criteria for anxiety and depression, which suggests that tracking the lasting psychological impact of COVID-19 will require measures for a variety of symptoms from several disorders beyond the ones that we typically look for, which are anxiety and depression. Beyond the patient-level clinical research we're conducting with Talkspace, my team has also engaged in ecological modeling of the pandemic, particularly within the context of identifying county-level risk factors for case fatality rate during the first wave of the pandemic. In a paper that was peer-reviewed and published earlier this month, we used publicly available data from the census to determine which county-level features were most strongly associated with increased and decreased lag-adjusted case fatality rates. The counties were split into training and testing data sets using a 2-to-1 ratio, and though we initially started with 64 features prior to variable selection, we ultimately produced a relatively parsimonious negative binomial model with a strong pseudo R-squared. The retained variables for which are shown here. Some of the more notable findings were that counties with a higher percentage of asthmatic, elderly, or Black residents exhibited higher lag-adjusted case fatality rates, whereas counties that enacted religious gathering bans and those that have more hospitals per capita exhibited lower lag-adjusted case fatality rates. Ultimately, we hope that work like this can help target resources to counties that need it most during future surges of COVID-19. Peer-reviewed and published studies aside, members of my group are big believers in preprinting work prior to submission to journals. So I'll also quickly highlight 3 preprints of ours that are currently under review at different journals. The first, designing efficient contact tracing through risk-based quarantining, uses agent-based models once again to present a new, more economical approach to contact tracing and quarantining that takes into account transmission heterogeneity. In other words, we argue that the fact that not all individuals are equally likely to propagate transmission after infection should be taken into account when determining how to allocate limited resources to contact tracers, both to reduce monetary costs and to more efficiently limit disease transmission. The second, evaluating criminal justice reform during COVID-19, the need for a novel sentiment analysis package, demonstrates the performance of several common sentiment analysis packages on a text corpus regarding topics at the intersection of COVID-19 and the carceral system, such as news media coverage about prisoner release programs to reduce jail-related disease transmission. Our primary finding is that existing packages are insufficient for this particular application, especially because most language about the carceral system is inherently negative, and thus we present 2 preliminary machine learning approaches to serve as the bedrock of a new sentiment analysis package that is tailored for criminal justice related research. And lastly, an inductive approach to using Google search trends to identify attitudes in areas of COVID-19 vaccine hesitancy is the latest study in our misinformation surveillance vertical, where we introduce a new method for generating and selecting Google search trends queries regarding vaccine hesitancy by leveraging keywords from applicable Twitter conversations and point-in-time surveys about vaccine refusal and acceptance, thus allowing for a broader number of highly relevant queries to be implemented for search query-based vaccine hesitancy surveillance than a single subject matter expert could produce on their own. And on that note, thank you all so much for listening. I know I've covered a ton of material today and I went a little bit fast, so we would be able to have some time to have a fun discussion at the end of today's session. But I hope that the 3 studies that I covered in depth and the several that I just mentioned in passing have effectively showcased a sampling of the advances that machine learning can achieve within the context of the ongoing pandemic and public health more broadly. Now, I would be more than happy to answer a few questions over Zoom, and please don't hesitate to reach out over Twitter or email as well.
You've overwhelmed everyone, Maya.
I know it was so much content. I know. But I figured, if there's going to be any group that would maybe enjoy it, would probably be this one. Mm-hmm. So I felt like now's the time.
I can ask a starting question, Maya, just to get the ball rolling. I'm sure others have many more questions. First of all, really brilliant talk. A lot of things that you've covered, and the work. I remember your work during the Ebola pandemic and our interactions, and this has come a long way. So a couple of questions, because we develop agent-based models ourselves.
Of course.
I know Alison, Jeff, and their group has developed a few agent-based models as well and published in PNAS. What do you think from the analysis you've done, you find something relatively innovative that these models were able to tell you that the standard compartmental models did not? And we get asked this question again, and we have some answers, but I would really like to hear what others think as well. So that's the
reason. Definitely. So I covered very briefly in the talk, the starkest contrast is, of course, with the simplest version of compartmental models that use ODEs and, have very little stochasticity built into them. So in comparison to those, I think that obviously it's pretty clear that by very carefully integrating different distributions that matter to populations of interest in ABMs gives us an edge over the simplest version. I think that what's tricky is that obviously mechanistic models are a spectrum in terms of their complexity, right? So you have the simplest version of your OD-based comparamental models, but then you have more stochastic comparamental models that are in between. You have metapopulation models and so on and so forth. And I kind of like to view this as a spectrum where you have the simplest stuff that's really treating populations as homogeneous on one side, and then you have on the other side where you're really modeling every single individual like an agent-based model would be. And then you have everything in between. And I think that there are different applications that are best designed for either end. So one of the areas where I think ABMs and other individual-based models are really effective are when we have good information on either the distribution of population-level beliefs and behaviors that might impact epidemic dynamics, or when we have actual individual-level information on behaviors that impact individual and population-level epidemic dynamics. And so the areas where this is most applicable right now are vaccines and vaccine hesitancy, and then masking and mask hesitancy. So since the beginning of the pandemic, there have been a number of very, very large surveys that have been conducted, some of which that are conducted on a daily basis that start to give us some insights into the population level distributions associated with masking acceptance and vaccine acceptance and so on and so forth. And so if we want to start integrating these into our forecasting models, I can definitely see where being able to parameterize each individual by drawing from these distributions could be a serious advantage, because then we're really maximizing the data that are available to us, as opposed to potentially, taking an average or taking the median or what have you. So I think that in a lot of ways, and this is one of the more common arguments that I hear for, why ABMs I think are especially now starting to see a heyday, is I think that the data that we have available to parameterize these models are different than they were even, say, 5 or 10 years ago. And I think everybody on the line is familiar, for example, with the fact that if you had told me 5 years ago that cell phone service providers would be giving us mobility data to use in our models for free, I would have been shocked. Like, I don't think I would have believed that would happen, but it has happened during the pandemic. And, now there are all these conversations ongoing with Google and Unicast and others about how do we keep this going for further and future epidemics, because, we still have flu and we still have other diseases that are going to pick up even as this pandemic starts to close down. So I think, again, the big benefit is maybe as we start to produce more data and get access to more data that is at the individual level or is aggregated in a way that allows us to determine the distribution in a population of interest, then I can absolutely see why individual-based models would be more effective at simply using the data that we have. So I think that's the primary argument that we like to make. At the same time, though, I think we also engage in much simpler modeling efforts. I think sometimes simpler is better, especially when you don't have enough information to parameterize a more complex model. And I think a lot of this comes down to being able to choose the right tool. So one of the big critiques is, oh, if you do agent-based modeling, that's all you do. And I think that we're trying to break that mold a little bit. I think as an entire community, we're trying to break that mold, because I don't think any of us believe that that's always the right application. And so I think that that's one way philosophically that this is starting to shift to. And as other researchers who use different types of models see us interested in their work, wanting to work with them, learn about their tools, I think it in some ways is making the environment more collegial, which is good. So those are, I think, some of my high level thoughts in response to that.
Wonderful. Thank you so much. I'll let others ask questions as well.
And next from Stephen, tracking misinformation spread is very different from counteracting it. Do you know of much research on what approaches work best to counter public health misinformation?
This is such a great question. And so I am working with a couple of colleagues at Northeastern, including Brooke Foucault-Wells, who some of you may know, who is kind of a guru in the space of quantitative social science. So I think that one of the things that I have learned from her is that there are a couple of really interesting advances that are happening right now in terms of identifying ways to counteract misinformation, not just about public health, but really about anything. There's been a lot of work that's been done in political science that I'm learning about through her. And so this again highlights, the importance of interdisciplinary research when we're doing work like this. But one of the things that I learned from her are really focused on, who has influence and on whom, and the amount of theory and study that's gone into this now. And so we have a couple of perceptions, I think, as lay people. I'll call myself a lay person here because I'm not a social scientist. But as a lay person who is not a social scientist, I had long thought that, like these really popular influencers who have gazillions of followers are going to have, a huge amount of influence on their followers in terms of the behaviors that they partake in, whether it comes to voting or wearing a mask or getting vaccinated. But through Brooke and through a lot of the work that she's shared with me, I've learned that that's not really the case. It's really about who you have in common in your network that also has commonalities with other people in your network. So it's people in your network who are well connected, but well connected within your immediate network. So the best example that I like to give is, the mom in the PTA at your kid's school who's like a little bit scary, but everybody knows who she is and she has like a lot of influence. So that's a really good example of a community influencer who's going to have a lot more effective of a sway on not just their followers, but the people in their community. And so generally these people tend to be, if you can identify them and convince them to kind of, work for the cause, that they can be very, very effective in terms of combating misinformation and also promoting good health behaviors. And I think that brings up a second point here where there's combating misinformation and then there's promoting good health behaviors. And there is a lot of intersection across them. And I do think that there is a school of thought that essentially says that if you are really focusing on helping people make better health choices, that will in and of itself combat misinformation. So really it's about improving the way that we are promoting our education campaigns, really doing one-to-one dialoguing with folks who need it, so on and so forth. So that's another area of research that's very interesting. And I think health communications research, health education research, there's a lot of really interesting content there in terms of, peer-to-peer education as being one of the most effective ways to get people to comply with interventions that they may view, especially as stigmatizing. So there's a lot of good work in this from STDs and condom use, but there have been some analogs now that have been developed between, COVID-19 and mask wearing, and the fact that especially if you belong to certain political groups and certain cultural groups, wearing a mask may be stigmatized. So how do you work with folks to understand that, your peers, some of your peers are okay with this too. So that's another really interesting area. And so I definitely agree that, getting people to change their behavior is very different from monitoring their behavior. But I do also think that surveillance is often the first step to being able to intervene. So one of the things that, our group is trying to do is we're trying to provide better tools to people like Brooke who really specialize in developing better interventions that are leveraging social science methods to understand who should be kind of recruited to help enact these changes that we want to see in the population. And there's some really interesting work happening at the intersection of computer science and social science here too, especially with complex contagion across multiple platforms. So that's something that we're really interested in too right now, when you have a person and they're on Twitter and they're on Facebook and they also have meet space people that they talk to at their hair salon or again at the PTA. How do you incorporate all of these things into understanding their beliefs and their attitudes and also ultimately their behaviors? So there's a lot of really interesting work. I think that these are still relatively unanswered questions, but that's also what makes them exciting.
Thanks again, Maia. That was fantastic.
Thanks so much for having me, everyone.
Thank you. We'll be in touch with you, Maia. Take care.
Sounds great.